Hi, everybody. Welcome. I'm super excited to be talking about this today and to share a little bit with you about my experiences about ketamine, its applications, substance use disorder, and how I've kind of woven this all into my practice. I'm going to give you a little background on me because it's been a fairly non-traditional road that brought me here sitting in front of you on a Thursday evening talking about ketamine and addiction. Um, I actually originally wanted to do OB and thought I was going to do OB, and by a series of other things, ended up doing primary care in Pennsylvania. And I was really fortunate. My program had a 1 month rotation in an inpatient facility, a rehab that's very well known, and we rotated through this inpatient facility. So what I ended up experiencing during that time was nothing I'd ever seen before. I did not know anything about addiction medicine and really saw how primary care so fits so well with substance use disorder, and how, as primary care providers, we were really the first line. We were really the first people that sometimes will be able to identify, will be able to talk to, and really be able to intervene and help people with substance use disorder. And that's everything from medication mismanagement, abuse, right, to alcohol use disorder, and then illicit drugs. And so that compounded with an opportunity during my residency to work in a methadone clinic really solidified that this was the field I wanted to be in. I worked for 2 years in residency also as an addiction doctor in a methadone clinic. And at the time, Suboxone or buprenorphine was just starting to be used for opiate use disorder. And at that time, it was interesting. There was a lot of stigma, a lot of misinformation about the use of medication-assisted therapy, such as methadone and buprenorphine. And buprenorphine, you may know, was the first medication that was given for opiate use disorder as an outpatient, because otherwise people in the United States had to come into methadone clinics and get dosed on a daily basis. And so there was a lot of misinformation about this and a lot of concern about giving people a drug that's replacing another drug. And in many ways, as I'm talking to you today, talking about ketamine and substance use disorder, it's full circle. I feel like I'm where I was almost, 20 years ago, with some of the same stigma, some of the same concerns, some of the same dialogue with psychedelic assisted therapy and substance use disorder. So that's a little bit about my background. I ended up doing primary care actually for only about 2 years, and then full time went into addiction medicine. I was fortunate to have worked in a really large methadone clinic, got to see what that world was like, and got a lot of experience, and then started doing private practice not long after that. The road has been interesting, right? We have a lot of medications, not tons for opiate use disorder, but a lot for mental health. And most people who struggle with substance use disorder also have mental health struggles. And the treatment that we have works, and they work for a reason, but there's some limitations. And that's really what I want to talk to you a little bit about. The applications and the usage of ketamine-assisted therapy is pretty broad, probably broader than you would imagine. And I do want to say this is all off-label, right? Because in the United States, there's only one FDA-approved medication for ketamine. Well, one medication for ketamine, and that's Spravato. It's a nasal application, and that's for major depressive disorder and treatment-resistant depression. What most people like myself do is we get ketamine from a compounding pharmacy in a couple of different variations, and we use them what's considered off-label. Really, the three ways that most people use ketamine would be with under the tongue, which is a troche, intramuscular, and then IV. I don't do the IV. I'm going to give you a little history about how that came about. Actually, I'm going to back up a second. Let me tell you a little bit about ketamine first. Okay. So big umbrella is we talk about psychedelic medicine. And when people think about psychedelic, they think about LSD, they think about mushrooms, right? And they're all under the same umbrella. But ketamine kind of has its own little cluster outside of that bigger umbrella. It's considered a dissociative anesthetic. So it works a little bit different than the classic psychedelics. And the way I like to look at it is psychedelics, if I'm in a ketamine room and I've got shades on and I'm listening to the music and I take them off and I look around, I may see things that are not there. I may see music or hear plants. I may have other experiences that are outside of what's actually there in reality. Ketamine does not do that. It's used, and it's been used for many, many years, is as an anesthetic in the ER. And so coming into it for a mental health and in substance use disorder, it sort of has a different it has a different approach, but it also has a different outcome, because if you take shades off when you're in a ketamine journey, usually nothing's really all that different. You might have blurred vision, but not a whole lot different. It's more of an internal experience. So back to kind of two different worlds that ketamine split off from. One is in the ER. It was frequently used for anesthesia. It was used in the military. Actually, if any of you have heard of the term K-hole, that comes from the military, in that the medics would jump into helping, like a foxhole or something, and helping someone who's been injured and give them a high dose of ketamine. And what would do is, it's a dissociative, so they're not really present anymore. It's an anesthetic. They can do what they need to do to patch them up. It's fairly short acting, and then they would send them out the door. And so in like slang, a K-hole in ketamine is when you kind of go really deep. We don't usually do it in those doses, but the history of it is kind of interesting. So anesthesiologists were fairly familiar with using this, and the IV model of ketamine therapy is usually anesthesia, usually IV, and is a little bit different than the way we utilize it here, and what I'm going to talk to you about. The way we use it is more in a therapeutic way. So what I mean is, there's an environment, which I'm actually sitting in my ketamine room right now because it's very relaxing. There's an environment that's usually, with nice art, low light, plants, there's music. There's that's the setting. There's an expectation of what the ketamine journey is going to be like. That's your mindset. And we talk a lot about set and setting. And that's really important for me to emphasize, because Western medicine, we have lots of options for substance use disorder and mental health, medications and therapy. But medications, the way I've always perceived it, is you take a medicine and you walk out the door on the way to work. You take your medicine when you're feeling anxious, so it does something to you. We're very passive in that. And the philosophy is, I take something in order to have an effect on me, is very different than come into this room, sit and have a ketamine journey. And together, we're going to explore what happens in the journey. But also afterwards, it's called integration. We're going to talk about this, and we're going to use what you learned and really apply it for days, for weeks, even sometimes for months. The medicine itself is sort of the catalyst and helps you have another way of seeing, another way of thinking, but the work is really done later. And that's a different philosophy than the Western philosophy of, let me take a medicine. I'm not saying that medicine isn't important. I utilize meds all the time. I'm a physician. I believe in antidepressants. I believe in anxiolytics. But I think what's been missing, especially with substance use disorder, is a different way to look at it. And ketamine literally does that. It changes the way we look at things. So one of the things I want to talk about is, like, what are the applications for it? So I mentioned that right now it's approved for major depressive disorder, treatment-resistant depression. I use it for so many things that I see on a day-to-day. And whether you're in primary care or you're a specialist, you're probably seeing people that are dealing with anxiety, that are dealing with PTSD, that are dealing with OCD, that are dealing with trauma. So many other areas I found that ketamine's really useful. It's not a one size fits all, and not for everybody, but it's a really important tool that I'm so excited to be utilizing, and that I found is remarkable. I'm going to share with you a little bit about why. So I have anxiety, I have depression. I've had it my whole life, didn't really know about it until college, and didn't really, I had a therapist during med school. I was on antidepressants. They worked. I don't tend to like to take medication. And when I first heard about ketamine, part of my interest, honestly, was selfish. I wanted to see if it would help me with my anxiety. I'm very outgoing. I'm very talkative. Most people that see me in the office wouldn't know that I have anxiety. But I do. And that's how a lot of people are. And so this journey has been personal for me also, because I have been utilizing ketamine with my therapist and doing integration. And I can tell you it's nothing short of remarkable. I don't have a protocol. I have to do it every so often. I kind of let my anxiety tell me when it's time to have another journey and to do the work. But personally, this has been nothing short of remarkable. And I think part of what it does is it allows, if we're talking about parts work, if any of you know what that is, it allows sort of this part of us that's always diligent and vigilant and sort of protecting us from all the things that are going on. So if my anxiety is part of protecting me for things, it kind of lets that part step aside a little bit. and lets you integrate other parts of you, lets you integrate other ways of learning, other ways of navigating some of the mental health things that people might struggle with. And then it ties into addiction, right? Because the root of a lot of substance use disorder is anxiety, depression, trauma. And so they really tie in well together. So I've found that personally, this has been pretty remarkable. Um, what I'd like to do is tell you a little bit about what it looks like here in the office, like what I see. And I thought about it, and what I'm going to do is give you an amalgamation of two different clients, right? They're kind of a combination, but two. So one would be somebody that I've seen for substance use disorder and has been stable and sober, either on medications or not that important to me, but that's not the issue, right? They're in therapy, they're on meds, but they sort of hit a wall. And either because of previous trauma or because of anxiety, they've gotten to a certain place, but they can't really get past it. And they're living, and many people are. You're able to live your life, you're able to do what you need to do, but you can't really get past that. And that's where I've seen ketamine be really remarkable. Um, I can't explain it, but this is what we see is it allows people to put down those defenses to really access their own inner healing, right? And do their own work, because it's different than me sitting here and doing therapy, or me sitting here and giving you medication. You're doing the work yourself. You're guiding it in many ways. And what comes up is what needs to come up. And what you end up working on is what needs to be here to be worked on right now. And so somebody like that who's been through lots of antidepressants, been through lots of modalities of treatment, DBT, CBT, EMDR, you name it, ECT, and just still hasn't gotten, and you've seen those people, regardless of what you do, we've all seen those people, and we're stuck. Like, there isn't a way to really help them. I've seen that psychedelic medicine, ketamine-assisted psychotherapy, really has been remarkable for that population. The other one that I've found that you would think it's almost counterintuitive is somebody who's still active in their addiction, somebody who's still relapsing, somebody who's still using, who's really struggling. And there's some good data. There's a lot of great studies out there that show it. But anecdotally, what I've seen here in the office is it really helps, again, the same thing, their own inner intelligence, their own inner healer is able to engage and do some of the work to understand, why is it that I keep relapsing? Why do I keep drinking? Why do I do well for a week, a month, 6 months, and then come back here in a way that a year of therapy, you might get there, but sometimes it's like watching grass grow. It takes a really long time. This kind of speeds it up. And it's been interesting, not for everybody. I mean, there certainly is a different response from different people. But I think as an add-on tool to some of the tools we already have that work for some, but not for all, this is remarkable. And I want to put in a plug. MDMA, I'm actually very excited for, because it works very differently. And hopefully in the United States next year, 2024, it will be legalized, because ketamine has a lot of great benefits, but it also there's some things that even with ketamine, it's hard to get past. I look at it as like coming up to the door and cracking the door open. You stick your foot through, and then some of the other more classic psychedelic medicine really does the work for getting you through the door. So that's a little bit about ketamine, shared a little bit about myself, gave you some examples. The other thing that I did want to bring up is, like, what are some of the barriers? And I feel like they're similar to the barriers that I saw way back in residency when I first started working with methadone and buprenorphine. The first one is education, awareness, right? People don't know. And you can't offer and you can't use something that you don't know. This isn't mainstream. There's stigma around it. Just like with buprenorphine, when it first came out, there was a lot of stigma about replacing one drug for another drug, right? Replacing one opiate for another opiate. Now it's very much the standard of care for opiate use disorder. And there's a lot of stigma around this because people aren't educated and aren't aware of it. Another one's access. It's hard to get. It's not covered by insurance. You need providers that are trained, which is why it's really important to get training in this. And you need to have a network of people. We were talking a little earlier before this started, how critical it is to have a network and how wonderful it is to start finding other providers, therapists, primary care, pain management, addiction specialist myself, addiction specialists, and have that network because we're all on different places on this continuity of treatment, right? We have inpatient from acute all the way to outpatient and everything in the middle. And my feeling is we all should know what the tools are and we all should be able to talk about it, even if this isn't something you may want to offer, to be able to know how to offer it to your clients and who to refer to is just as important. I think one of the other barriers is resources. We need resources. We need to be educated more about it. We need to have more availability. So like I mentioned, I don't think I finished that part of it. I'll come back to it. I use a compounding pharmacy to get the medication, and we need more ability to get the medicine. So the one FDA approved medication in the United States, I'm just going to loop back to this for a minute, is Spravato. It's nasal, intranasal ketamine, and it's S-ketamine. What most people use that's from a compounding pharmacy is a racemic. It's R and S. It's kind of like mirror molecules and thought to have better efficacy, thought to have better results. And you can get it made in all different kinds of formulations. So what I use here are troches, which dissolve under the tongue, or intramuscular. People also can do it IV. And I've actually also used it, not a lot, but very low dose daily to take orally. And we could talk about that later if anybody's interested in asking me. But there's some research that shows that very, very low dose ketamine on a daily basis can help also with depression, anxiety, PTSD. So let's see, how am I doing on time? I want to make sure we have enough time for Q&A also. Okay, I got the thumbs up, Natalie. So education, accessibility, resources, and then the stigma. I mean, I can't emphasize that enough. People frequently will say, well, the party scene, the club scene, I know people that did acid. I know people that did ketamine. I know people that did all of this and they didn't have these incredible aha moments and they didn't have it and it was used as a drug. And here you want to talk about giving it to someone who struggles with substance use disorder? Yeah, my answer is yeah. I do. And it works. And it works because you have to think about the whole picture, right? You have to think about somebody's coming into the office. They're seeing you as a therapist, as a physician, as a provider. They've got, if they don't, we're going to help them. They've got a network of other resources. And you're creating a safe environment, like a capsule for them, that's going to hold them. And the medicine is the vector that gets them to where they want to go. So set and setting is something we talk about all the time, and that's really critical. So yes, if I were just to give you 20, lozenges of ketamine and said, go home, use this, and good luck with it, I'll see you in 30 days, I would agree. It's definitely has the potential for abuse. But if you come into the office and we do it here and we talk about it and we integrate it, and either I'm working with you or your therapist is working with you and you've got support at home and we're talking about diet and exercise and smoking cessation and the whole package, you can imagine how this would be a much different experience than a party drug. And that comes back to education. I could probably talk about this for another hour, but I'm aware of the time and I want time for questions. So, that's kind of a cliff notes of a little bit about ketamine, how I utilize it, a little bit about my own personal journey with it. And hopefully there'll be some great questions. Thank you.
Thank you, Dr. Forrest. So appreciate that. Your very comprehensive sharing of just not only your experience, but how it's really impacting your patients. And just a little heads up for you, we will have Q&A at the end. I'm going to have Rev share a little bit first. So I see a few already going, some comments and some questions in the chat. If you want to put them in there, we'll be able to see those. We do have a few. We might be able to take a few hands up at the end as well. So if you have them and you want to put them down in the chat box now, feel free to do that as well as they're top of mind for you. I want to just give the floor to Rev Darda for a few moments. I just want to give you a brief introduction. She can certainly share a little bit more about her work and what that means for clinical protocols and regulatory maybe needed in Canada, maybe beyond those borders. What does that look like? A little about what Atma is doing to help support those who maybe want to begin offering this. Reverdy is Reverdy, I'm going to say that correctly, is the president and CEO for Senna Life Inc. With over 30 years of experience as a registered nurse, her experience and expertise in the areas of community engagement, planning, project, and change management have significantly impacted outcomes of numerous projects that she's been involved in. She understands the challenges that healthcare systems and their structures have in offering consistent, reliable, client-focused services. And she is passionate about bringing evidence-based innovation forward to those in need. I can certainly concur with that, having sat in meetings with her. Her professional career includes executive leadership roles in the public, government, and nonprofit sectors. She currently sits on the board of MAPS Canada. She has a passion for lifelong learning and easily unites individuals to achieve common objectives, goals, and outcomes. And with that, I want to pass this over to you, Rev, to talk a little bit about what is a bit of your passion in bringing this forward in this clinical setting. Over to you.
Thank you so much, Natalie. Can you hear me okay? Everyone can hear me okay? I'll just spend a few minutes because I'm very mindful of our time as well. And thank you so much, Dr. Aviva. That was wonderful. I'm very excited to hear a little bit more at the end about what I would call protocols or program approach, because I think maybe our audience might be interested in that. But maybe I'll jump in to start with. I am the president and CEO of a clinic, a psychedelic-assisted therapy clinic that is operating out of Edmonton in Alberta in Canada. I am very pleased to be joining in a partnership with Atma that we can look at how we identify and spread not only opportunities amongst other clinics, but really create a network nationally so that there is a focused support on understanding and being able to provide information related to clinical programs and program approaches, potentially regulatory requirements. I had the good, or I don't know, timely, fortunate experience that Alberta in Canada has been the first province to institute regulations and service standards for psychedelic drug treatment. And in that, I think we're learning so much, but we have the opportunity in building some of our program and protocols to be able to pass on those lessons learned and share them. So today I wanted to talk a little bit about, in the same vein as Dr. Aviva, addictions. And really my context is the Canadian context. But here in Alberta and other jurisdictions, they do have regulations around mental health service protection. And so I identify and ask, if you are from a jurisdiction in Canada or across North America, it would be good to be familiar with that, because there are certain practices and protocols that are focused mostly on the safety of clients who are entering in those treatments, to be able to ensure that regulated professionals, those with training, those with knowledge, those that are connected in the ecosystem, have the tools that they need to support the best outcome for the clients that are seeking service. And here in Alberta, we have 4 different types of addiction treatments. I think Dr. Aviva alluded to the same across the states. There's really the public stream, the private stream. We have inpatient and outpatient. And currently here, we're spending a lot of additional public dollars on focusing on addictions treatment. And I think we're trying to bring forward a change to, as was stated earlier, some of the stigmas that come along with introducing new approaches, new therapies, new treatment, new medicines to the way that we treat addictions. And both, as you said, substance use disorder, active and stable addictions, those that are currently being treated with MAT or medication-assisted therapy. So Canada is no different than any other jurisdiction, and moving forward and focusing on the need to bring these types of services to clients and practitioners. I wanted to share a bit here in Alberta that we have an emerging service delivery model around ketamine, and the opportunity to integrate that with some of our addiction treatments, I think, is in this time. As Dr. Aviva said, we're using ketamine for many off-label indications, and addiction, substance use disorder would fall into that category. I think we're looking at lots of the evidence and data that's come out, and lots of the practitioners and prescribers' personal lived experience about the goals and the outcomes that their clients have. So I would urge that as we work together and as we learn, we will lean into the evidence, but we will also look at operational best practice. And I think that's where Dr. Aviva today can share more of some of how her protocol, using both what I would call the psycholytic or low dose and psychedelic or high dose in combination with that therapy, and have substantial impact on those with substance use disorder and addiction. And what does that timeline look like? I think that we think about it in terms of maybe some of the way that Western medicine protocolizes it. And I want to re-emphasize that the individuality and the timeline will vary. And you will have people that enter in and out of treatment. And I think that's where the opportunity lies to be able to support them. I wanted to identify in that some of the opportunities, just looking at the time as well with Atma. So as part of our partnership, we are identifying several streams where we would support the opportunity to build a network that can be connected and share more about not only the regulatory requirements that we've learned about in Alberta, so specifically service standards around psychedelic drug treatment and in support of the regulations, but that we would also be able to support and provide training. So those that are interested and seeking out psychedelic assisted training, to being able to adopt some of those innovative approaches for many of those conditions that we spoke of, spanning the range of addiction, treatment-resistant depression, major depressive disorder, and general anxiety disorder. So I think the opportunity here is to share with you that whether you're an individual that may be seeking this service, whether you're a practitioner and also a practitioner who maybe have a client or a panelist, or whether you're a clinic, that we are looking to expand and build that network across Canada so that we have the opportunity to offer not only information, expertise, guidance, these types of services in your area, because we do realize that based on, I would say in Canada and specifically parts of the US, some of the density of our population and access to service can be very limiting. So how do we get the information and the expertise out there to be able to have individuals who are in the field understand and be supported by the experts who can guide some of those program and protocol approaches? So I think that's it kind of as an overview. I do want to say that just, and I'm going to make an assumption that ketamine used with addiction treatment is not common. You will not see that across Canada in a common place or a common opportunity that's being offered. So I do think it's important as we find pockets of excellence and expertise, like Dr. Aviva, that we are asking and learning about those protocols and adopting them, and then continually looking at some of the outcomes that we're receiving to be able to ensure that as we adjust our program and protocol approaches, it is in the best interest of those clients. So I think the opportunity for us is now as we're practicing in the field, and I just encourage you all, and hopefully in this next 20 minutes, we'll get some of that great Q&A going to be able to bring forward what questions you have and be able to answer them or get back to you with those answers to allow you to make some decisions about whether or not you'd like to be part of some of the services we're offering in our partnerships, create that network that we're looking for across the country, and then be able to share some of the great learnings that we have from the experts that are providing us with their insight and their lived experience here today.
Thank you so much, Rev, for that, and for your expertise and what you have to lean into the whole clinical side of what we have here. We're certainly thrilled to be partners with you. From Atma to Sun of Life. Also, I want to just mention too, but just before we jump into questions, that Dr. Aviva has actually joined our roster of instructors for our advanced course and will be contributing more intensive and deeper understanding of this work of ketamine and how it works for substance use disorder. So it's exciting for us and for our students that will be partaking in that. But we're going to go to some questions here. There are questions for both of you. So what I'm going to do is give this first question over to you, Aviva, from Rick from Stony Plain. Dr. Aviva, do you recommend a second attempt at ketamine-assisted therapy if the first try does not seem to work for a client? That's a good question.
It's a great question. And here's what I would ask, Rick. What does it doesn't work mean, right? So when we talk about intention, which is part of preparation for ketamine and any of the psychedelic work, a person's intention or what they want out of it is something that they go into a journey thinking about. But that might not be what they get out of it, right? So people will frequently say, I went in saying, I want to learn about my anxiety, right? Using me as an example. I want to learn about my anxiety and understand it. And the journey might take me in a totally different place. And then what does it mean it doesn't work? So did I not learn about my anxiety? Maybe not. Maybe the anxiety wasn't touched at all, but maybe I got something else out of it. The other thing is maybe I had a journey and got nothing out of it. I think that's what you're saying. I would probably be curious. Is it actually possible to get nothing out of it? Because even going into a journey and having a ketamine experience and then working through, I had the expectation of something. I had the expectation of having a certain type of experience, and it wasn't what I got, right? And how do I navigate that? And how does that apply to day to day? And the reason I'm kind of spending a little bit of extra time on this is with substance use disorder, a lot of times people will come in, see me for the first time. I might be the very first person they've ever shared that they're struggling with, fill in the blank, whatever, it doesn't matter, opiates, alcohol, misuse of their benzos. And I'll get asked like, well, what's your success rate? And I love that question because I'll say, what do you define as success? Like, what's success, right? Are you just stopping? Is that your success? Do you have a balanced life? Is that your success? Are you going to be gainfully employed? Do you get your driver's license back? Do you feel better about yourself? Do you no longer have shame? Like there's so many facets. So when somebody says, I didn't get anything out of it, I would probably dig a little deeper and say, well, what was your expectation? And what did you get? Because sometimes that's enough. I hope that answers the question.
Mm-hmm. This leads just right into another one here, just about vulnerable patients that may be challenged, who may be vulnerable to psychosis. How do you protect that when you're considering that, working with these? I'm not sure if they go together with alcohol use disorder, but perhaps maybe they do.
Yeah, so there's a fairly extensive screening process that I have before we would have this. And there are certainly people, I could talk about inclusion and exclusion criteria, but there are certainly people that would not be appropriate. I wouldn't feel comfortable doing this work with them. And one of those would be a history of psychosis, bipolar disorder with a history of mania. I certainly know there's studies out there where they're looking at that. And I also know that some people have a higher degree of comfort. For me personally, I tend to be a little more conservative. So it's a great question. And maybe at some point, as we learn more about the medicine and as we have more experience with it, that population may be offered this. I wouldn't.
Okay, thank you. Thank you. There are a couple of questions. I'll maybe put them together once, wanting to hear a little bit more about microdosing ketamine. And then another question that's talking about what's a good frequency of the Troche work, like once a week, every 2 weeks, once a month. We'd love some protocol ideas and maybe talk a little bit about microdosing at the same time, what that might look like.
Sure. So I'm going to share the low dose daily is certainly not standard of care. It's kind of in the same line as psychedelic, psilocybin microdosing. I've had some people that were very refractory. So I'm going to start with that in saying that I'm still learning. I mean, that's part of what I love about this is we're all still learning, right? And I'm not going to sit here and say, I'm the expert. Let me tell you how this goes, because I'm not. We're learning from our clients. We have a network of people that we can learn from together. And I think that's the beauty of where we are in this field right now there's so much to be learned. So my experiences have been thus far that I haven't done just straight low dose oral ketamine. The way I've been utilizing it is, and it ties into your other question, the other question that the person had, Natalie, is what is a protocol? So my philosophy is this isn't a one size fits all model. I don't believe in that. And I don't believe in that with medication assisted therapy. And I don't believe in that with psychedelic assisted therapy. That being said, people want to know, like, how do you, is this an every day? Is this a once a week? Is this a twice a week? So the studies that were done, because they had to be done this way in a very rigorous and standardized way, were usually 2 ketamine sessions a week for 4 weeks, 8 sessions total. For some people, that is actually very useful. And the population that I found that that's the most useful is major depressive disorder, like treatment-resistant depression and major depressive disorder. Outside of that, the protocol can be anywhere from once a week for X number of weeks to 1. And then they do really well. And I really believe in meeting people where they are. So, you know, my first go around is usually let me do, Rev talked about this a little bit, the difference between a psycholytic and a more like psychoactive, a higher dose. I usually will start with a psycholytic dose, which basically is talking about a lower dose where people can still interact. They're a little more relaxed. They're a little more able to access different things. They're able to open up a little bit more, but it's not a journey, right? Unless they've had experience with this before. And that kind of opens the door, but also relieves some of the anxiety that sometimes people can have about using psychedelic medicine. And that gives us a gauge also on how the next journey can go and what they get out of that one. So let's say it's anxiety or depression and they get resolution, right? And then we do an integration session and then we continue to work either with their therapist or here with us. And it lasts for a month or it lasts for 2 months. That's great. We're still seeing you. You had that one ketamine journey. I'm really happy it's working. These are the things that you got out of it. And the miracle is like it does work even after that medicine is out of your system. I mean, it's pretty remarkable how it does that. But let's say you don't. It's like a rubber band, right? You get snapped to this other place. You're in a different place, a different way of thinking, and then you snap back. But like a rubber band, you don't come back exactly to where you were when you started. And then the next ketamine session, you go out and you're in a different place. You have these realizations and you come back. But again, not to that same place. And I really believe in listening to what I'm being told. Let me hear what's happening. So is it once a week? Is it once a month? I had somebody that had 4 or 5 sessions, really did well, and then stopped for 2 months and really in the 3rd month started doing poorly, came back in and said, listen, I think I need to come in for another one. So we decided, okay, maybe the sweet spot for you is every other month for a while, right? Every 8 weeks, let's do this, 7, 8 weeks, and then we'll see if we can stretch it out to 3 months. And then where I've used the low dose or the micro dosing is with somebody who got some results, but for one reason or another, the one person I'm thinking about in particular wasn't able to come back in, and it was, it's kind of a long story, but wasn't able to come back and wasn't able to do a deeper, more intense ketamine experience. So what I decided to do, much like microdosing with psilocybins, which there's some thoughts that works as well, is to try low dose. I worked with the compounding pharmacy because as somebody who works with substance use disorder, my concern is always misuse, abuse, right? Is how are they going to, how can I be assured that this isn't going to be potentially not good for them? And what we ended up landing on was having the compounding pharmacy make them in capsules and then put capsaicin in it, which is a derivative of the pepper plant. So if you open it and want to snort it or do something with it, you're going to get a really bad headache. It will not be pleasant. And so the only way you can really take it is orally. And it worked. Yeah, it worked. I think we were 8 weeks, something like that, about 2 months. And then they made a decision to stop. I could talk more about it if you want, but I'm going to give some other questions an opportunity.
Yeah, we have some great questions here, let me tell you, and they're coming in. Thank you so much for contributing these questions as well. And we'll do our best to get to as many of them as we can before the time is up here. I think I'm just going to pop over to Rev for a minute. There's a couple of questions here that maybe you could answer about liability insurance, implications to consider, how you work with this. And then maybe I'll get you also, how does someone, say, particularly in Alberta here, or perhaps in Canada, get experience being able to come alongside someone to watch as part of the clinics and maybe our upcoming clinic network? Maybe there's some answers here, possibilities.
For sure. Thank you, Natalie. So the first question, specific to Alberta, and I would say across other jurisdictions in Canada, most regulated professionals are involved in current ketamine-assisted therapy clinics. So by a regulated professional, that is defined as somebody who has a college that you register with, that they on an annual basis update and have confirmation of their licensure. So when we talk about liability insurance, it falls under professional liability and that of your regulator or being a regulated member. There is a type of liability insurance called errors and omissions. And so as you as a regulated professional are seeking insurance, usually those things are combined. So your college registration and then professional liability insurance come together. If they do not, you would be wise to seek out and understand for yourself, if you're a private in private practice, an errors and omissions policy around professional liability. I want to also be clear, though, that if you're part of a clinic, individuals within the clinic should also be covered. And so that would be the clinic or the owner of the clinic's responsibility to not only have what we call commercial general liability insurance, but also to have errors and omissions or professional liability coverage as well. So those things cover service and advice that's offered within the context of the program. So here in Alberta, I can speak to my college, and I know that we also carry professional liability insurance. I do know many insurance providers will offer you errors and omissions insurance that supports and covers program and service advice, and that would be the responsibility of that business or that clinic owner. I hope that covers that. And so there are many different providers that offer that. So I think these are some of the things that we would like to offer advice. We could identify what some of those providers, who those providers might be, and then help connect you, whether you are a regulated professional or you're a clinic, to be able to support you in identifying and understanding kind of what you need to be covered. And then there's always I would think, the opportunity to ensure that those that you work with also have equal and supportive coverage. And then the other question you said, specifically here in Alberta, how do you get experience? And I think that is a really important point. It's one thing always to take theory and education, but I think that hands-on piece is really where we come into feeling, comfortable and confident and more competent in our skill set. So specifically, wherever ketamine clinics are, I think more and more individuals are looking to offer opportunities. I think it says there for shadow or mentoring. So based on the clinic, I think and your area, two things can happen. We are offering that as part of our clinic network service. So please feel free to reach out, submit your request into us. As we grow our clinic network across the country, we will be able to find clinics that have the opportunity to support and provide some of that experiential or hands-on learning. Things that might come along with that is just to ensure both you're protected and they're protected, so confidentiality agreements and some support in that, but definitely to be able to get that hands-on experience early and to be able to decide if this is right for you. And so I would suggest, first of all, you can reach out to us, but there may be clinics in your area, in your vicinity, and I think there's lots that are looking to have that connection or network into the community, whether that's with other practitioners or providers, or to engage people to be able to have that. So that would be my suggestion about that. Reach out to us, but that would be an opportunity for you to come on in and observe and see specifically around ketamine-assisted therapy. And then I do know many clinics are evolving their programming. So as we've talked about here today, whether that's psycholytic, psychedelic, off-label use, chronic pain use, addictions use, I think those things are starting to grow. So depending on where you're located and if there is a clinic near you, if not, reach out to us and we'll try to make some of those connections for you.
Excellent. Thank you very much, Rev. Some really good connecting points there. I also saw some busy messaging going back and forth among those who are here tonight. Mark Cornfield and Susan McBride do teach for us, and they do work with ketamine as well. They might be worth connecting with as well if you're in Ontario, if you are interested. So I have a couple more questions for you, Dr. Aviva. There's a question about the difference between psilocybin and ketamine. What might the differences be, and how might you choose one over the other? Is that a question you feel comfortable tackling tonight?
It's a good question, but no, because we're not using psilocybin medication legally. There's no, so ketamine is really what we're using. From studies, you can read about what the differences are and how they'd be used, but there's no availability to use that at this point until it's legalized.
Mm-hmm.
Yeah.
Thank you. Thank you.
Yeah.
And, you could probably speak to some of the differences in clinical trials. A ketamine treatment would typically last, you can confirm this, probably between 30 and 90 minutes, whereas a psilocybin treatment would be a more extensive 4 to 6 hours, and usually time on either side of that preparation. And so just in time alone, there is a difference with that, for sure.
Yeah,
But
very.
a question for you. There's a couple of questions about what else ketamine might be helpful with. Can people with ADHD, not on meds, be helped with ketamine? If yes, how could this be done? Is it something that you're working with that particularly? Or I think there was one other one. Is it good for end of life as well? If someone's some distress. So a couple of applications, maybe, if you want to address what it might be good for.
Great question. So there's a lot of work that's been done with end of life care, and it's certainly been found to be very useful. I don't do that work, but yes, very useful for end of life care. And, we had talked a little bit about the difference between psycholytic, and then I didn't really talk about a psychedelic dose, but that's where it really is more useful. The experience is a little bit different. It's more of a dissociative experience, and depending on the dose and how the person responds to it can even, I don't know if you're familiar with this concept of ego death, where really people are on completely a different plane and anywhere in the middle, and it's hard to, if you're doing it in a troche or intramuscular, harder to adjust, because once they're on the dose, that's the dose that they have. With the IV ketamine, you can have a little more adjustment as the journey is continuing, but that's been found to be useful. As far as ADHD, I'm not really personally using it for that. My sense is, again, if it's just executive function, it probably could, but if there's other things that come along with it, such as depression or anxiety or any other things that could come with focus problems, it would be useful. And my sense is we're going to be finding that it's useful for more things off label than we're even aware of right now. It happens. So somebody has anxiety, social anxiety. That might not be what comes to their mind when they think about the anxiety, but it ends up helping. And then if it's helping in social anxiety, it's going to help in other areas as well. Trying to think of other applications that I've seen in the office. Some of the other things that have come up are people who have eating disorders. I mean, really, like, that's not what they're here to see, but then they tie in, right? Because it's a little bit different than like the monoamine, like an antidepressant, where we're working just on the depression. It seems to affect people in a much more, like I said, 3-4 dimensional way. And so other parts of their lives are benefited. So that's what I've seen anecdotally here.
Great. Thank you. There's a really interesting question here when we talk about a window of neuroplasticity, when we say it kind of opens things up. With ketamine, I'm guessing they're directly addressing ketamine. Is there a therapeutic window of neuroplasticity? How do you take advantage of that? What that might look like?
Yeah, that's a great question. And I wish I had a way to image it. I don't, right? But it's there. And a lot of it really depends on like post journey. Again, I can't emphasize enough how important it is to integrate and to have continuing treatment and to have it be part of a larger picture, because that neuroplasticity, I have had somebody that had one intractable anxiety, intractable, one ketamine journey, and literally 5 months and still going, doing well. I mean, it's remarkable. So are they still in this neuroplastic place? Are they, I can't explain it, but the way to take advantage of it is just to really emphasize this is one part of a bigger, not to have expectations that the journey itself is going to give you all of these insights, because sometimes it's not that monumental in the journey itself. Sometimes it's more either a somatic thing, like I just feel relaxed. I haven't felt this relaxed in a long time, or I sort of saw a lot of pleasant things, but it's not, what I expected, having these aha moments. But then in the days, weeks, months following, they're able to do things that they weren't able to do before. They're able to integrate in a way they weren't able to integrate before. And so I really always emphasize it's part of a bigger picture. Again, I really believe in meeting people where they are. So where's that window of neuroplasticity and how far is it open? It's open as long as you're telling me things are working and you're applying it and you're continuing to engage in recovery and in treatment. And then when things like the rubber band concept comes back, then okay, I guess that window is shut and it's time to think about, are we going to have another journey again or not?
Mm-hmm.
Good question.
Yes, excellent. Now, here's one last question. We're just right down to the last of the hour. If you can maybe answer this quickly, I can probably add something to it. Getting comfortable prescribing ketamine for those who are physicians or potentially prescribers in this info session, or maybe those who will be listening later. Specific training to gain that kind of comfort in utilizing that ketamine treatment. I know you're on the US side, so I might just pop that over to Rev on the Canadian side too as well.
Mm-hmm. So I think it's really important to have an experiential training. In my opinion, this is very different than a physician who's prescribing antidepressants, cardiac meds, diabetic meds. I don't think I necessarily have to be on insulin to know how insulin works and to know how to utilize it. This is different. This is different. It's like nothing else as a physician that I've ever worked with. And I really believe in the experiential part of it. Number one, because I have more understanding of what my clients are going through. Sometimes sitting in a journey is 3 hours of nothing. They're completely silent, completely internal. Nothing is happening. And sometimes it's a very engaging, very alive kind of a session. And so I think getting experience doing it is really important. Sorry, it's the end of a very long day. What was the
That's okay.
What was the rest of that question?
I think you actually answered that. I think that's
okay, that's great. I'm going to tap out
and
and let Rev take over.
I'm going to throw it to Rev because you do work with ketamine in your clinic. What do you recommend to get comfortable with the idea of prescribing it or offering that? Because it's something we can do now, right?
Yeah, I agree. And it's different, as Dr. Aviva had said. So there is a motto with some things: start low and go slow. So I think that's a really good thing to remember. And different than other medications, there's a range. So if you're a prescriber, it starts within that range. So when we think about, a prescription and doing that with an interdisciplinary team over the course of several treatments, I think standardly we're quite low, like 0.5, and I'm speaking to intramuscular here, milligrams per kilogram, to a range of a 2.0 milligrams per kilogram. So that range covers that entire treatment program timeframe. And Dr. Aviva said that could last, 1 week, could last 4 weeks, could last 6 weeks. We usually here, in my experience, prescribe that over 4 to 6 sessions with check-ins in between for the prescriber and the interdisciplinary team to talk about how is the client doing, how are the gains, what are the gains the client's making, and how did that client respond to that initial dose. Because sometimes, as Dr. Aviva said, you may have a dose that's giving you 3 hours of internal silent introspection, or you may have a dose that the client is in and out of right away. So my recommendation advice would be start low and go slow. Always look for a range in the prescriber or in the order that's provided, and that encompasses the time frame that you're currently engaging with the client over, which is usually 4 to 6 sessions, but can be adjusted and set specific to the individuality and the response of that client.
Great. Thank you. Both great answers. I will tell you too, if you're unfamiliar with the programming that Atma offers, we do have a physicians and prescriber course where we are very specifically targeting or you giving the information that would be pertinent and necessary for prescribers who want to, begin working with not just ketamine, but also MDMA and psilocybin as those become available and legal to use as well. And we have great information on all of the neuropharmacology of these different medications and how they work. So that's maybe a really good place to start, just getting familiar with what they are and what they do in the body and in the experience, along with a lot of other information from a number of different experts. So that might be a place to start as well on the theory side. Totally agree on the experiential part, knowing what you're actually offering when it comes to these medications that you're going to be offering.